just going to start talking on newer strategies for fixation of ankle fracture, then briefly touch upon on syndesmosis, end it with a few cases, interestingly, newer concepts of how we do it. So what is the objective of this talk is first and foremost understand the anatomy, posterior, especially the posterior malleolus and syndesmosis, which is a new battle to be fought, the deltoid complex. What better tools do we have to fix or assist in fixing? That's the anatomic plates and arthroscopy assisted fixations, and better understanding of complications or complicating factors like the diabetes and osteoporosis, and how we can get our patients faster return to activities of daily living. So as what Dr. Bagaria was asking was, there are two columns concept in ankle. One is the medial side and one is the lateral side. We all know the anatomy very well, but these are the two columns which we need to stabilize. Why this is important? Because now ankle stability is looked upon as a ring. It's not only the bones, but it's also a soft tissue complex which is comprised of the anterior inferior tibiofibular ligament, the posterior inferior tibiofibular ligament, which actually constitutes a ring. So if there is a single break in the ring, we consider it as a stable fracture and we can deal with it minimally invasive or conservative. But if there is any double break or if the ring is disrupted, it's an unstable ankle and it needs to be addressed to get a better outcome. So understanding the full extent of injury is very important to give our patients a better outcome. So generally they are malleolar fractures, trimalleolar fractures, but they should be distinguished from pylon, which are higher energy injuries usually caused by the impaction of the talus on the distal tibia. So for surgeries, there can be, like, one of the indications of surgery is syndesmotic instability. That's what my talk was about. And you see syndesmotic injuries in supination external rotation, that is 3. Like the force has exited up to the posterior malleolus. Similarly, posterior pronation external rotation and pronation abduction. All these 3 types where the force has exited through the syndesmosis and gone on to the posterior side. That means there is an anterior break, the lateral and the posterior break is where we look at syndesmosis. So these are the 3 types that we see. They are unstable injuries, they are equivocal or at risk injury patterns, and radiographically you can watch for the medial clear space of more than 4 millimeters or the tibiofibular clear space of more than 5 millimeters in an AP view. That's how we look at it. How do you test it? Like, how do you diagnose an instability of an ankle joint? Intraoperatively, you can do the hook test, but again, there are a lot of controversies in syndesmosis. One of them is this: how do you evaluate? The hook test gives you a pull outwards, but it can also be a pull up and downwards, that is in the sagittal plane. You can also have it, as sir said, in the coronal plane. And there could be a big rotational element to the syndesmosis. So what we feel is, it's very important that you get the syndesmosis back directly under vision, slightly expose it a little bit more, see that the fibula is sitting into its incisura nicely. So intraoperative hook test, it was opening, this was done. So the controversies are diagnosis, how to diagnose it, whether it is like clinical by external rotation, pressure, or imaging wise. Management, again, to operate or non-operate. Implants, which implants, whether it is screw or whether it is a suture button, whether to remove the screw or let the screw to break or not to remove the screw, and how do you rehab them. Again, the angle at which it's important, the fibula sits around 20-25 degrees posteriorly, and it's important that you get the alignment in the correct direction. It could be a single 3-cortex screw, a single screw which is 4-cortex. You could be 2 screws 3-cortex, which makes it 6 cortices. You can be 2 screws 4 cortices, 8 cortices. All things are there. There is no one evidence that, since there are so many options, that means no options are correct up till now, or no option has been proved to be the most correct up till now. Similarly, tightrope, single tightrope, double tightrope, pant over vest types where there is a screw and a tightrope, or both ways are available. So you can do all kinds, but main thing is to get the fibula back into place, let the ligaments heal. Along with the syndesmosis, there is a medial collat or deltoid ligament injury many times. So whether it is indicated to repair them, routinely not required. You explore the medial side if reduction is not anatomical. Again, the MCL or the deltoid is also a component of the ring, and if you have a break in the ring, it makes it unstable. Again, pronation, external rotation, pronation, abduction is unstable. You need fixation. The controversy is supination, external rotation 2 or supination, external rotation 4. 2 is stable and can be treated non-surgically, especially for the deltoid. And 4, where the deltoid ruptures are there, you need to fix them. So how do you assess stability? Stress X-rays or weight-bearing X-rays. These are gravity stress X-rays. On the edge of the table, you let the patient's foot fall externally and you take a good AP, and where you see that it's opening up like this, where it tells you that the gravity stress is opening the deltoid and there is an insufficiency, where routinely this would have been your X-ray. So it's important that you diagnose them, and this is done normally and at 7 to 10 days where the patient is relatively pain-free. Again, you need to estimate it and make sure that you repair it. Better tools or assist in fixation are better anatomic plates nowadays, what sir showed already. Better hold fragment specific plates are there. Arthroscopy assisted ORIF is done especially for osteochondral lesions of talus and the syndesmosis, which we'll be showing. Again, this is a posterior malleolus which we did many years back. But you could see a die punch which could be brought back and fixed with your plates. Again, accuracy of syndesmosis is best judged by an arthroscope, where normally you have a 4 shaver, and if you could run your 4 shaver up into the syndesmosis, that means it is unstable, and you could use it to bring it back, and you could also see that the fibula is sitting back in the incisura correctly. Better understanding of complications or complicating factors like the diabetes and osteoporosis. Again, you need stronger construct, longer period of immobilization, and strict vigilance to make sure that it doesn't progress to a Charcot. So you need, this is like what we call it as a pro-tibia transfibular screws. Pro-tibia screws, you put more screws, you give it a more rigid construct and don't allow it to progress to Charcot. Faster return to activities of daily living. There is a trial which is IW-BAT trial, that is immediate weight bearing as tolerated trial. In a stable osteosynthesis, they found that only 1 out of 26 patients lost fixation, is when they could allow them to bear weight immediately as soon as the pain allowed them to tolerate. So take home for ankle fractures would be assess and take care of soft tissues, understand mechanisms, especially Log Hansen is extremely good to kind of understand things. Ring stability, medial and lateral columns with intercalated ligaments, achieve anatomic reduction of bones, beware of potential syndesmosis or deltoid injuries, identify and treat it appropriately, use newer tools like arthroscopy, assisted fixations, and in diabetes and osteoporosis, make sure the medical management is correct. So finish this, we'll just discuss 2 cases which will help us maybe awake some of our sleeping boys behind. So 22-year-old male, twisting injuries 2.5 years back, diagnosed with an ankle fracture. This was the fracture. An attempted close reduction was done. Would anyone accept this? Ronak? Please read the X-ray, Ronak. You would accept this X-ray? Okay. Good. You're not doing foot and ankle. Okay. So diagnosed, it was treated surgically and mobilized. This was his X-ray, and once syndesmotic tightrope was put. But unfortunately, you could see that it is still opening. And he complains of pain and limp while walking. Now, this is how he walks. The left hind foot is affected. You see that he has significant valgus. External rotation test was painful, and weight bearing x-rays, you could see on the normal side that there is a good overlap, but over here there is widening. And any additional investigations like MRI, we got an MRI and we could see that one, the tightrope was not in proper alignment, and the syndesmosis was opening posteriorly, and this was what it was. So, and on CT scan, you could see there is an ossicle over here and there is early little bit of a chondral wear. So diagnosis left with us was left ankle early osteoarthrosis post ORIF with syndesmotic instability. Any plan of action? Anyone, sir? So our plan was either, or rather options for us were conserve, wait for full blown osteoarthritis, then we can fuse or replace. But he is only 22. Yes, heavy, but only 22. Or we intervene right now, and the options were either we fuse it or we osteotomize and get the whole stability back. So we did an arthroscopic evaluation, joint cartilage evaluation, debride the syndesmotic space. We stabilized it, that is we refixed it, the reconstructed, and our options were either we reconstruct the syndesmosis or go in for a synostosis. So on arthroscopic debridement, we could see that the syndesmosis was wide open. We got the fibula back to length, and we could actually see a small loose body over there, and that's one of the best advantages of having an arthroscopy on your table while you're doing such revision cases. So that's my lateral portal, and once you start debriding the synovitis, which is there because of the instability, as my shaver went in the syndesmosis, we could see that the loose ossicle started slowly peeping out. This is what it was, which actually didn't allow the syndesmosis to sit back in place. By now, it had become a loose ossicle, so we got the syndesmotic ossicle out. And then we went on to do something that's been described by Bjor of reattaching the AITFL. So you move the distal end of AITFL attachment, which is stretched out. We move it proximally and cranially and refix it. So this is what was done. We kind of stabilize it secondarily with our small plate and two screws. And this is how he could walk later. This he had come with the opposite knee with a locked medial meniscus. The left knee was operated the first time. This is his right knee, which was he had come for a meniscus. So we could do a syndesmosis, we could debride the space, loose body, get the fibula to length, and syndesmotic stabilization, which allowed him to relatively preserve his joint space later. Next case is of a ligamentous syndesmosis. Again, 17-year-old male, engineering aspirant, twisting injury during football. This is what it was. Any plan? Anyone? What all do?
Interpose in the medial clear space, so you will have to explore that.
Sure, sir. Correct. So there is a medial deltoid, and yes, we need to fix it, like explore it and then repair it. And any on other imaging, we also saw that the AITFL was also completely torn, and that made it an unstable injury. Plan again, we did an arthroscopic evaluation, joint cartilage evaluation, debride syndesmotic space, stabilize and repair the deltoid. So again, over here, you could see that the syndesmosis had kind of bunched up over there. After debriding the whole thing, we could see that the syndesmosis is also open. We had a small plate kept over here. Once we brought things back in place, the deltoid with an arthroscope was also cleared. The medial gutter was cleared, and then a deltoid was repaired with one anchor because I prefer a double breasting of the deltoid with an anchor over there. So ligamentous syndesmosis becomes like what I say, I feel in my head is like a ligamentous Lisfranc. Sometimes you need to stabilize it, otherwise the patient might end up with early arthritis. It's important. Thank you.